On AM 970, The Apple.
Folks, we were actually debating this ourselves. Hopefully we can answer a question that was texted in by the end of this segment. Let's go to our pop quiz. What percentage, 30, 40, or 50% of patients who have a coronary artery calcium score greater than 400 will have a positive or abnormal nuclear stress test? Nearly 50% of patients with coronary calcium scores greater than 400 will have an abnormal nuclear stress test. Now, contrast, less than 2% of patients with a calcium score of less than 100 will have a positive test, for everybody out there. So, our section 4, as always, what can you do about it? We put it all in perspective, hopefully, for all of you. One of the most important applications of using non-invasive testing is to determine the appropriate therapy for each and every patient out there. So if you have no symptoms but have coronary risk factors, the coronary calcium score may be of significant particular use.
I agree.
An example of this would be to have somebody that has mild cholesterol or mild blood pressure elevations. A coronary calcium score can help your primary medical doctor or your cardiologist to decide whether to treat you more aggressively to prevent further development of plaque, as well as prevent the clinical events that we just showed you can occur. Medications like the statins in this case can therefore be prescribed. Nuclear stress tests can be performed in those with scores between 100 and 400, the intermediate scores. Another group of patients who can benefit from this approach are those with what is known as metabolic syndrome, or as we called it in our show, the Big Mac attack. That show we called There's No Such Thing as Borderline Diabetes. Those metabolic syndrome people, or the Big Mac people, are overweight, they have high blood pressure, they have low good cholesterol, high triglycerides, high fasting sugar. Many of them could be considered intermediate risk patients, and a coronary calcium score, if they have no symptoms, would be often have shown, and they've done studies to show that they're going to have greater than 75% of them are going to have high levels of calcium. So it places them at a need for more intensive risk factor management. And that's the key here, folks. Doesn't mean you're going to get a catheterization. It doesn't mean you're going to get a stent. And that was where all the argument went for this TV show last week.
One of the arguments for calcium scan, because right now, no one, aside from United Healthcare, which pays a little bit, no real insurance company pays for this. The thing about calcium scanning is it going to re-stratify you to either a low risk or a high risk, and it can do that. There's a lot of data that says that. The argument against calcium scans is they say, well, there's no data to suggest that if you have a high calcium scan and I treat you, then I'm going to prevent an event. Yeah. But as I'd like to point out, as my mentor, Dr. Heck, points out, that does not mean that the scan produces bad results. You have high calcium, you're high risk.
Right.
It's not a failure of the test. It's a failure of the treatment. We have to figure out a way to prove that treating the high calcium, and we don't have that data yet.
Exactly.
But you are still high risk. If you have a high calcium score, you're still high risk. The data is incontrovertible.
And you tell me this all the time. And I was just going to repeat exactly what you said. Although screening for heart disease with this CAT scans and lately with nuclear stress tests as well are not widely reimbursed by insurance companies, the acceptance is really gaining. Now, a useful approach can be following. First, we establish your risk, low, medium, or high, and in terms of whether or not you're symptomatic or asymptomatic. So if an asymptomatic, low-risk person can be just counseled on lifestyle changes, such as diet and exercise. Patients who are at high risk are considered to have high risk for coronary artery disease, and that could be considered an equivalent nuclear stress test at this point may be utilized to determine if catheterization should be performed, especially if we see a moderate or large size defect on your nuclear images. Likewise, although not quite ready for prime time, the coronary calcium score, as Dr. Kaiser was saying, can be performed. The intermediate asymptomatic patient is one who really benefits from this coronary calcium score with medications, as we talked about, or nuclear testing, or invasive catheterization being performed if your score is less than 100, between 100 and 400, or greater than 400, respectively, as Dr. K just talked about. Because a substantial number of heart attacks still occur in men greater than 45 and women greater than 55 years old who are determined to be, quote-unquote, low risk. Plaque imaging with these coronary calcium scans with subsequent testing using nuclear tests need to be considered based on other risk features. And I want to make sure you're going to, again, as we always say, see your doctor, ask your doctor, present to your doctor from that standpoint. This will be dependent on whether or not your physician is interested in aggressive primary preventative practice, as we all should be, and we're all moving towards, folks. So using these study in patients with symptoms involves deciding whether or not you should have the full CAT scan, angiogram, or nuclear stress testing, or going right to the lab for a catheterization. One suggested, and we need to know what the gold standard is, and hopefully we'll get to that in a second. One suggested approach is for that person who is intermediate to have the CAT scan angiogram, and if abnormal, have a catheterization, versus the high-risk person who should just go right to a nuclear stress test to determine the functional severity of their blockage. So those deemed of the highest likelihood for heart disease, on the other hand, we might just go straight to the cath lab. So in summary, we have reviewed 3 forms of non-invasive coronary artery disease testing. The coronary artery calcium score and the coronary CAT scan angiogram allow us to directly visualize in the former and the severity in the latter of the coronary plaque. The nuclear stress test allows us to assess the functional or clinical severity of those blockages. Each of them has their strengths and their limitations. Ultimately, all 3 have considerable overlap in their utilization, and I refer to one of my top 10 Dr. Scott quotes: medicine, folks, is not one size fits all. And that puts it all into perspective. What's the gold standard on the final word?
Well, if you go right now, the gold standard is the invasive catheterization. That's what everything is referenced to. But that may not be true.
But that's the donut.
That's
the donut hole.
That's the hole in the donut. The CAT scan angiogram not only looks at the inside of the vessel, it looks at the wall of the vessel. It can look at calcified plaque. You can see non-calcified plaque. It looks at the whole vessel wall. So, you can make a case that maybe the gold standard should be shifted to the CAT scan angiogram. That's a debate, and I would bet
the debate is ongoing and ongoing and ongoing. And every analysis is going to have to keep on going for until we finally get to a point from reimbursement standpoint, from a cost efficacy standpoint, and from predictive modeling. Right. In other words, who's going to live, who's going to die, who's going to get what. We're nowhere near getting an answer from this.
Unfortunately, the reimbursement is lagging behind the science. It's really unfortunate in this setting because the CAT scan angiograms, we should, as physicians, we should be able to tailor our therapy to our patients, not dictated. Here's our my political statement for the day, should not be dictated by the reimbursement, because we should be doing the right thing. And sometimes the CAT scan angiogram, or certainly the calcium scan, is the right test for the patient.
That's true. And we will tackle the whole stent versus bypass.
That's going to be
we're going to have a whole show. We're going to do it in the coming months. So everybody's going to have to stay tuned for that one. So that's it for this week. Tune in next week for Leaky Pipes, Don't Call a Plumber, the mystery and mayhem of mitral valve prolapse, a little joke from heaven. Please tune in next Sunday and learn all about this very, very common problem. We welcome home my brother-in-law, Gunnery Master Sergeant Chad Backestow from active duty.
Thank you for your service.
Yeah, well, we're glad to have this future daddy on American soil. Our prayers go out to all U.S. military serving abroad. Tune in to smarterheartuniversity.com for all of our shows. Always up for your higher heart learning, and register there with Facebook for your daily heart updates. Remember, friends, as always on Smarter Heart University, get to it before it gets to you. Be well, be safe, have a great week.